Welcome to AETCM, the Emergency Medicine channel. Today we'll be discussing a case of acute stroke that was presented to our ER. A 69-year-old female was brought to ER with complaints of right-sided weakness and aphasia since that day morning. So, initial 10-second assessment, patient was conscious and obeying commands, and she was triaged to the red area. So, we went to the primary survey. Patient's airway was patent. There was no secretions and no airway compromise. Breathing, patient had adequate chest excursions bilaterally, maintaining a saturation of 98% in room air, and had a respiratory rate of 18 per minute. Air entry was bilaterally equal, and there was no signs of any aspiration, no added sounds, crepitations were present. Coming to circulation, patient had a blood pressure of 120 by 70 millimeters of mercury with a pulse rate of 88 per minute, and it was sinus regular in rhythm, and had good peripheral pulses palpable. Patient's disability part, patient had a GCS of E4V aphasia and M6, but right side hemiplegia.
What type of aphasia it is?
It was like motor, sir. Patient can't speak. Patient understands everything and obeys, but she can't.
She's not able to
speak out.
Okay.
And pupils were 2.5 millimeter bilaterally reactive. So right side power was 0 by 5. Left side she had 5 by 5 power. Both upper limb, lower limb, right side weakness was there. And also there was facial deviation, angular deviation to the left also.
Where is the dominant hemisphere?
Sir, mostly in all the right-handers and most of the left-handers, it will be left side.
Okay. Let's say if aphasia is associated
with
right-sided weakness.
And exposure temperature, patient was febrile, and GRBS checked, and it was 120 milligram per deciliter. Sir. So, since it is a acute stroke, we had immediately asked for the onset and the other history. So the patient was sleeping and was not at normal last day night, and today morning at around 6 o'clock, when the bystanders went to wake her up, she couldn't speak and she had a weakness, and she was immediately taken to our ER in less than 1 hour. So it is a wake up stroke, sir. Basically the onset of stroke time we don't know. Okay. Last found normal was around last night 10 o'clock. Okay. And there was no history of any no involuntary micturition, any involuntary defecation at that site where she was taken from. There was no history of fall. She was found on her bed itself, and there was no obvious tongue bite or any secretions, anything suggestive of a seizure at that point. So the other assessment, the second sample history, patient is a non-case of CAD and had underwent coronary angiogram, and a primary a PTCA was done around 20 days back. Basically she had a unstable angina for which a diagnosed with a single vessel disease, and a PTCA was done, and she was on ecosprin and Brilinda, ticagrelor and aspirin, and she was also on atorvastatin, she was on telmisartan and bisoprolol, and also she was on metformin for diabetes. So basically CAD, diabetic hypertensive and dyslipidemic lady, and history as suggested, went to bed in a normal state, found to have the weakness, and taken here.
So will you give in this type of patients loading dose of aspirin, clopidogrel and statins?
Sir, it is like a wake up stroke. So even in wake up stroke, according to some recent...
No, he is taking already these medicines. So will you give it or not?
No, we have to confirm there is no bleed, sir.
I'm not asking that. In a patient who come with a stroke, suppose if bleed is ruled out, you have to give loading doses of all these drugs. Okay, in peripheral settings, not in these settings. Peripheral settings, when you are working, if you are ruling out a bleed, you have to give aspirin, clopidogrel, statin.
We can continue the same thing, sir.
I am asking whether again you give an additional dose or not.
No,
It has to be given because that's what most of the textbook says. You give another dose because we don't know whether patient has taken, whether patient is misleading you because they have a stroke. They may not remember, or they may be telling false information. So ideally, even if the patient is on the drugs, better to give.
So like here like we had to check if the patient like is a like though thrombolysis and all is for like a window period stroke, but like we don't know the onset. So in according to some trials, if the patient MRI is not suggesting a flare change, even thrombolysis can be attempted.
Okay.
But and in such a patient like also vessel anatomy also we need to check for, because and if it is like after 4.5 hours, like maybe within 16 or 24 hours, some endovascular therapies like a thrombectomy all can be attempted. So we had gone for a MRI with a MR angiogram, sir. So in this patient there was acute infarct in the left frontoparieto-temporal lobes and adjacent left gangliocapsular region, and the MR.
So it's a multiple vessels are involved here.
Basically MCA's M1 territory was involved,
Okay.
and also there was some occlusion of ICA also.
Okay.
And so that was the MRI finding, and there was like flare changes also. So it is like out of the period of thrombolysis and all. And so we went that was the imaging done, and examination, as I already told, CNS examination had a right side hemiplegia and facial deviation, and other system examinations were within normal limit. So apart from checking the GRBS, we had also taken an ECG in the primary assessment. So ECG was showing normal sinus rhythms. There was and some normal sinus rhythm and features of LVH. Okay. Nothing else was there. And
what is the feature of LVH?
Basically, there will be S wave, the S wave in V1 plus the R wave in V6. This amplitude, it should be more than 35, and if it is a LV strain, there will be T inversions in the lateral leads also.
Okay, is it LV strain or
no LVH features? No,
only LVH.
LVH features with it.
Okay.
And
will it confirm left ventricular hypertrophy?
We have to do an echo also.
Okay, so only voltage criteria. Sometimes it can be there, sometimes it may not be there. But strain pattern, most of the time, if it is there, it is confirmation of LVH.
So this patient, so ECG, GRBS was checked. Then we after securing IV cannulas and all, we shifted her for the imaging. When we got her back, this was the findings. So basically, it is an acute infarct out of a window period, and even in this patient, a thrombectomy was also not attempted. So she was admitted to ICU. She was since it was a very large infarct, we have to suspect anytime the patient going into a hemorrhagic transformation and all. So we have to have a continuous GCS pupil and BP monitoring, and we have to while prognosticating also we have to explain the bystanders regarding the same. And treatment part, we can continue the patient on antiplatelet. The patient was continued on ecosprin, and also anticoagulation can be started, sir. So this patient was started on low molecular weight heparin. 0.6 ml, 0.4 ml BD dose was started, and apart from this, other thing is how
do it will help the patient? Low molecular weight heparin.
Basically, thrombus anticoagulation further. One is
anticoagulant. It's not an anticoagulant, no?
It potentiates the activity of antithrombin 3 and factor 10A inhibitor. So it prevents coagulation
in arteries.
One is Dvt prophylaxis. It will happen.
It will only prevent the propagation of thrombus. That means the increase in amount of thrombus formation after an injury to the blood vessel. Okay, there is a thrombus which has got a covering. It will not lyse the thrombus. Okay, or it will only prevent further propagation of thrombus. And like you told, Dvt prophylaxis is another important thing. Okay, don't think that it will go and lyse the thrombus which is situated there.
Aspirin, then the anticoagulant, then statins was continued. Then other thing is there is a chance of patient having aspiration. Like if she can't orally tolerate, we have to go for a RT insertion and early enteral feeding. Then other thing is if there is a edema, anti-edema measures should be started. We can start a hypertonic saline.
CT shows any.
This patient didn't have any edema features, but it was a large infarct. So we targeted to keep the sodium at the upper limit of normal, like around 145.
If there is no edema, also we have to keep it in that target. This is only treatment of edema. It is not a preventive strategy.
Here the patients CT and MRI didn't show any edema, but it was a very large infarct.
Okay.
Then other thing.
What is the age of the patient?
Patient was 65.
Okay. What are the conditions where there is a large infarct will not produce any major problem like raised ICP?
One is elderly, the brain size will be atrophied.
Okay. If an atrophied brain, no need to worry about raised ICP.
Then one thing is already if a flap is there post some cranectomy, then also
that patient also we no need to worry.
That is one thing. Then enteral feeding started. Then glycemic control, like the patient sugar was targeted.
Sugar is normal only.
Here normal. So we monitored it when TID and sugar was always kept in a normal range between 140 to 180. Then other thing is the echo should be done and to rule out any vegetations or any thrombi, LA thrombi, anything is there. But echo is also normal. Then patient, initially the patient...
What are the conditions which are prone for thrombus from the heart, cardioembolic?
AF is there.
AF.
So valvular lesions, MS and all leading to
any valvular lesion which produce infective endocarditis.
Infective endocarditis and also the clot also.
Okay.
Then if there is a PD and all...
Procoagulant condition, it doesn't arises from the heart. It can arise from anywhere.
Then other is when if there is a PD or anything, there can be clot will go.
If there is any part of the heart is not moving, like severe failure, left ventricular failure, aneurysms of left ventricle, all these things can produce embolic, cardioembolic. But like you told, commonly is always atrial fibrillation.
So that from the heart, that these are the causes.
Okay.
Then other thing is Dvt prophylaxis, we have to keep the patient on. Then the patient will be having deficits, so we'll have to prevent bed sores and frequent.
What Dvt prophylaxis you give?
This patient is already on low molecular heparin, so we can continue that. If it is a bleed or something, we can go for pneumatic compression, stockings and all those things also. Then frequent.
But best one is physiotherapy, movement of the limbs.
Then frequent position changes should be done. Then this aspiration prevention basically this antiemetics all should be added. Then head and should be elevated, so at least 30 degree of head and elevation should be there. Then prokinetics should be added. Then ulcer prophylaxis should be given, pantoprazole and proton pump inhibitor should be added. And as early as possible, patient should be started on physiotherapy and mobilization activities. Glycemic control 140 to 180. BP, this patient had a blood pressure of 120/80 on presentation. Later also the blood pressure was within normal limit.
But ECG shows LVH. Echo?
Echo showed sir didn't show any concentric LVH. And some RWMA was there, recent ACS.
Okay. So ECG sometimes it may show large voltage complex, but it may not show in echo.
Only some RWMA was there. That is a recent ACS history is there. Then other thing is Like a vessel also we had analyzed. So
Doppler study.
that is
And MRI itself.
angio was there.
Angio.
So some ICA eccentric filling defects of ICA was also there, along with an MCA M1 segment MCA occlusion. Then so basically these are the things we like manage in ICU, that BP control, then like adequate GCS monitoring, like, and if there is a fall in GCS or pupillary asymmetry involving a neurosurgical team as well, then the antiplatelets, anticoagulants, then like electrolyte abnormality should be like corrected, along with the Dvt prophylaxis, ulcer prophylaxis, with preventing bed sores and early mobilization and early enteral feeding.
Okay.
So
if this patient comes in less than 4 hours, what do you do?
So basically,
4.5 hours.
If it is a patient coming in a window period, that is, if less than 3 hours for age, less than 3 hours any age group, and like 3 to 4.5, if it is less than 80 years, we can like go for a thrombolysis if there is no evidence of IC bleed, and there is no hypoglycemia, and after ruling out any other contraindications for thrombolysis, that is if the patient has a history of any IC bleed, any history of acute stroke in the last 3 months, any head trauma like with a bleed recently, history of active GI bleeding, then all these things. Any ICS or like malignancy in the intraaxial malignancy, neurological malignancy, then spine surgeries recently. All these things are the absolute contraindications. In such a case, if the absolute contraindications are ruled out and the CT is not showing any features of bleed, we can go for a thrombolysis. So thrombolysis we can do it with alteplase. So the dose is 0.9 mg per kg, and in that initially like 10% should be given over 1 minute, and the remaining should be given over 30 minutes. Over 60 minutes. So that is the protocol of thrombolysis. Other drugs like tenecteplase all can be used. That is a weight-based dosage.
And during thrombolysis, what are the complications you anticipate?
So one is an IC bleed, sir.
So most IC bleed is not very common.
The other
common
is
things.
Anaphylaxis can happen.
Okay. What is a common problem you have observed during thrombolysis? Any thrombolysis, whether it is cardiac or neuro. When you are starting the drug, what are the complications? May not be a complication.
One is BP control should be
BP fall. BP can be reduced in any thrombolytic agent when you are giving. Since it is an allergen, some patients can develop hypotension. They may not go to shock. So many patients can have hypotension. Then
angioedema.
Anaphylaxis and angioedema. Okay.
Other thing is bleed transformation.
Percentage of bleed in stroke?
Like while thrombolysis. Not sure.
If it is 15%, up to 15%, patient can have bleeding, especially in large thrombus. Okay. So we have to explain that in detail to the bystander before thrombolizing. Okay.
During thrombolysis, like what we have to monitor is, we have to monitor the one thing is blood pressure. So BP initially first 2 hours we have to monitor it every 15 minutes. Then after that from 2 to 8 hours every 30 minutes. After that we can monitor it hourly. Okay. Then other thing is, prior to starting thrombolysis itself, the patient like if requires RT or like Foley's and all, it should be like secured, and IV cannulas, adequate IV cannulas all should be secured, and we should avoid any arterial punctures or anything for the like next 24 48 hours. Then other thing is after thrombolysis, if like even if the patient is improving or not, like if it is a candidate for thrombectomy, we have to get a vessel study. That's a CT angiogram or a MR angiogram should be done. Based on that, that we have to plan for a thrombectomy and all if required. Then these are the main things of thrombolysis.
Okay. How is the patient now? What all things you have done? after that initial treatment?
So this patient, sir, came on out of ventral period, so was started on like the platelets and all the anticoagulants and all the treatment. So like sensorium is good, but like the deficit, she is initiated on physiotherapy, so it will take some time to improve. But she had not developed a complication like bleed, or like any aspiration or anything. And after 48 hours of observation, she was shifted out of ICU.
Speech, what happened?
Speech is like same only.
Not
There's
improved.
Not improved.
What are the speech disorders you know? It's a basic question. Speech disorder.
Sensory aphasia,
That is aphasia. Basic speech disorders.
dysarthria,
Dysarthria and aphasia or dysphasia. Okay. What is the difference between dysarthria and dysphasia?
Dysarthria, patient can articulate the speech. Basically, it's cerebellar involvement.
Only cerebellar involvement.
No.
What are the components of neurological system can produce dysarthria?
Patient muscles can cause dysarthria. So then tongue, like
Lips, tongue, gag, that is 9th and 10th cranial nerves, and cerebellum, all can produce dysarthria, whereas dysphasia is produced by motor, what is it? Broca's area and Wernicke's area. Broca's area is involved means he cannot talk. Wernicke's area we will not be able to understand. Okay.
That will be sensory.
Okay.
So these are like then sometimes patient can speak something absurd also. That's sensory.
Okay. Patient will, that is verbal diarrhea. Patient will be talking continuously, but there will not be any content. That means patient is not able to analyze. But she is able to talk. Okay. This patient is not able to talk, so it is aphasia, motor aphasia. Okay. Anything else you want to add in stroke?
Stroke basically, sir, like initially, if it out of hospital itself, it's very important because according to the new guidelines and all, if the patient is brought to a hospital within 20 minutes, we have to get the imaging done ideally, and within 60 minutes, the patient, if a candidate for thrombolysis, should undergo thrombolysis.
Okay, dot to needle time.
Sir. And since like the action of alteplase, everything, it is time dependent. So early intervention is very important.
Okay.
Then other thing is,
how do you dilute TPA, tissue plasminogen activator? Have you diluted?
It is coming as a 50
and 20.
50 and 20. It is coming and it is coming as a powdered form, and the diluent itself is available.
It's water, 10 ml saline.
It is available as a separate.
How do you dilute?
We have a connector which will connect both.
No, you have to dilute the 10 ml to the powder.
And as an infusion, we have to like.
How do you dilute it? Shake?
No. You get a 50 mg bottle. Along with this, you get a 50 ml of sterile water. So it is basically 1 mg gets diluted in that 1 ml syringe. Then both will come as a sterile bottle, and then you will have a connector in between. And then you just have to like upturn the sterile water into the powdered form of it, and then that itself will get mixed.
I am asking, will you shake it or not?
It won't shake.
Why?
It gets like part suspension.
All this, whether it is thrombolysis or whatever medicine contains protein. Okay, if you shake, what will happen?
Clumsy.
It will produce a lot of froth in that. So you cannot inject it. It will be wasted. So in that you have to slowly, what is it? You move it like this. No, there is a way of diluting it, but you should never do it. Most of the staff will do like that. They shake it. That will completely drug will become useless. So that should be very carefully handled because it's a very costly drug. Okay. Anything else you want to add? Nothing else? Okay. Thank you.